Greetings. Today I will be discussing with you a brief overview of the contents of the Manual of National Standards in Infection Prevention and Control for Health Facilities, 3rd edition. The objectives of the presentation are as follows: to provide background information to the new National Standards in Infection Prevention and Control for Health Facilities, 3rd edition, and, second, to provide a brief overview of the contents of the manual. These national standards are part of the DOH Health Facility Development Bureau Integrated Hospital Operations and Management Program and Continuing Quality Improvement Program. Department Circular No. 2021-0447, issues the dissemination of this Manual of Standards. Let us begin with the brief overview of Chapter 1 on the Standards on Management, Structure, Functions, and Responsibilities. There shall be an infection control management structure under the Office of Chief or Director of the health facility with sufficient resources and clear lines of responsibility. There shall be a functional IPC program in the healthcare facility. There shall also be clearly defined objectives based on local epidemiology and priorities, according to risk assessment and functions that align with and contribute to the prevention of healthcare-associated infection and combating antimicrobial resistance through infection prevention and control good practices. This slide shows the responsibilities of every health facility head in terms of infection prevention and control. Establish, organize, monitor, and support the Infection Prevention and Control Unit. Designate managers of the IPC unit. Ensure that the IPC unit members are qualified and trained. Monitor or track records on IPC procedures and reports. Address efficiently and effectively all IPC concerns. Adequate resources and budget shall be allocated by the hospital to support the implementation of IPC programs and activities. The health facility shall establish an active and effective infection prevention and control unit. The IPC unit shall have a functional relationship to the Infection Prevention and Control Committee. The IPC committee shall be directly under the Office of the Chief or Director of Hospital. Here we see the difference between the IPC unit and the IPC committee. The IPC unit is responsible for the day-to-day IPC activities. They respond to urgent problems of IPC. They monitor compliance to IPC policies and recommend actions to the IPC committee. The IPC unit is composed of the IPC unit head, Infection Prevention and Control Nurse, and Infection Prevention and Control Surveillance Officer. The IPC committee formulates and updates IPC policies, guidelines, and procedures. They also design the training for infection prevention and control in the health facility. They prepare, review, and evaluate the progress of the IPC program. Lastly, it is a multidisciplinary committee. Full list of the responsibilities are seen in Chapter 1 of the manual. Finally, all healthcare facilities shall have an infection prevention and control assessment tool containing guidelines on core components of IPC programs that shall be implemented. We now move on to Chapter 2, chapter on the standards on guidelines, policies, and procedures. The IPC committee initiates the development, implementation, evaluation, review and updating of written evidence-based guidelines, policies and procedures for the prevention of infection and reduction of antimicrobial resistance within the healthcare facility. There are infection control guidelines, policies, and procedures for specific patient care areas and for hospital auxiliary service departments or units. There are infection control guidelines and policies related to purchasing of drugs and medicines, medical equipment and supplies. The IPC unit shall coordinate with the Antimicrobial Stewardship Committee with the implementation of infection prevention and control programs, and antimicrobial stewardship programs, as per Administrative Order No. 2019-0002, implementing guidelines on the Philippine Antimicrobial Stewardship Program for hospitals. The IPC unit is responsible for creating, developing, promoting, implementing, and monitoring adherence to the guidelines and policies. The evidence-based guidelines are reviewed regularly. Data indicators as well as standardized forms shall be provided for the monitoring of adherence of each unit or department. The following shall be routinely monitored and reported: hand hygiene, surveillance of healthcare-associated infections, needle stick injury, antimicrobial resistance, breaks in IPC protocol, respiratory hygiene and cough etiquette, and environmental care. All microbiology sections shall adhere to the laboratory standards of their respective institutions, in addition to those set by Administrative Order No. 2021-0037, new rules and regulations governing the regulation of clinical laboratories in the Philippines. As such, they shall submit reports on time to the necessary offices and agencies. For referral testing of samples, all microbiology laboratories must follow a standard protocol on proper collection, handling, and transport of laboratory specimens, pursuant to the standards stated in the aforementioned administrative order. Finally, all microbiology sections of the clinical laboratory must have an efficient and effective biosafety program management to protect its laboratory personnel from exposure to infectious agents. Biosecurity programs shall likewise be instituted to prevent loss, theft or misuse of microorganisms, biological materials, and research-related information. Chapter 3 is the Standards on Infection Prevention and Control Education and Training. There shall be adequate resources available in the health facility for the required education and training activities. There shall be qualified staff that oversee the IPC education program and are trained through modules and programs with endorsement from the Department of Health. There shall be allocated budgets to allow regular attendance of IPC members to continuing educational opportunities to infection prevention and control training and conferences. There shall be coordination with other departments or units in the conduct of IPC education and training. There shall be available and accessible venues for teaching and training. There shall also be materials and updated tools needed for IPC education and training. There shall be involvement of the IPC unit in the orientation, training, and continuing education of healthcare staff and administrative staff. Orientation shall also be given to patients, relatives, and visitors. There shall be infection prevention and control educational programs focusing on relevant topics appropriate for specific clinical settings. The following are the recommended topics: basic epidemiology of healthcare-associated infections, hand hygiene, isolation precaution, decontamination, disinfection, and sterilization, care of environment and healthcare waste management, needle stick injuries and blood and body fluid exposures, healthcare worker infection risks, prevention and immunization, tuberculosis, HIV, hepatitis B, emerging and re-emerging infections and pathogens, and rational antibiotic use. Finally, there shall be tools to measure knowledge, skills and attitude of staff and trainees on infection prevention and control practices, and procedures, for example, equipment disinfection methods, when and how to isolate patients, after the implemented training. Moving forward to Chapter 4, the chapter on healthcare-associated infection surveillance. The World Health Organization defines healthcare-associated infection as an infection occurring in a patient during the process of care in a hospital or other healthcare facility, which was not present or incubating at the time of admission. Healthcare-associated infections can also appear after discharge. They also include occupational infections among staff. There shall be a defined program of surveillance and reporting on, but not limited to, healthcare-associated infections, needle stick injuries, blood and body fluid exposures and antimicrobial resistance, and breaks in infection prevention and control protocols. Healthcare-associated infection surveillance as a minimum requirement at the primary facility level should follow national standards. The IPC unit shall set the surveillance process. They shall also collect and analyze data, through developed standard reporting forms, and provide reports at least annually. Lastly, the IPC unit shall coordinate with the Microbiology, Antimicrobial Stewardship Committee, Pharmacy Therapeutics Committee, and Pharmacy in the development, implementation and monitoring of antimicrobial stewardship. Let us now go to Chapter 5, an overview on the standards on multimodal strategies. The infection prevention and control programs and activities of health facilities shall be implemented using a multimodal strategy and a multidisciplinary team approach to improve practices and reduce healthcare-associated infections and antimicrobial resistance. The facility's leaders, managers and key players shall practice multimodal thinking, which means that a person does not focus only on a single strategy to change practices, but consider a range of strategies that target different influencers of human behavior. The facility shall identify champions who are respected individuals with strong communication skills, and who are knowledgeable and enthusiastic on IPC. They shall promote and lead healthcare-associated infection prevention initiatives by engaging and educating colleagues, solving problems, and communicating across all levels of leadership. The 5-step approach to IPC improvement shall be followed by the facility to support IPC activities and programs implementation, which is grounded in the principles of successful change and improvement in healthcare. The health facility shall implement the 5 common elements of multimodal strategies. Let us discuss briefly the 5-step approach to IPC improvement. Step 1. Preparing for action. This step ensures that all of the prerequisites that need to be in place for success are addressed. Step 2. Baseline assessment. Conducting an exploratory baseline assessment of the current situation, including the identification of existing strengths and weaknesses, is critical for developing a tailor-made action plan that addresses the reality of healthcare facilities. Step 3. Developing and executing an action plan. The results of the baseline assessment support the development and execution of an action plan based around a multimodal improvement strategy. Step 4. Assessing impact. Conducting a follow-up assessment using the same tools as in Step 2 is crucial to determine the effectiveness of the plan. And Step 5. Sustaining the program over the long term. An important step in the cycle of improvement is to develop an ongoing action plan and review schedule to support the long-term impact and benefits of the IPC program. The 5 elements of multimodal strategies are as follows. First is system change or build it. When implementing hand hygiene interventions, ease of access to hand rubs at the point of care and the availability of wash infrastructures are important considerations. Second, training and education or teach it. When implementing injection safety interventions, timely training of those responsible for administering safe injections, including carers and community workers, are important considerations, as well as adequate disposal methods. Third, monitoring and feedback, or check it. When implementing surgical site infection interventions, the use of key tools are important considerations, such as surveillance data collection forms and the WHO checklist, as adapted to local conditions. Fourth, reminders and communications, or sell it. When implementing interventions to reduce catheter-associated bloodstream infection, the use of visual cues to action, promotional or reinforcing messages, and planning for periodic campaigns are important considerations. Finally, culture change or live it. When implementing hand hygiene interventions, the way that a health facility approaches this as part of safety and quality improvement and the value placed on hand hygiene improvement as part of the clinical workflow are important considerations. Chapter 6 provides us with the standards on monitoring, audit, and feedback on infection prevention and control. A well-defined monitoring plan with clear objectives, targets and activities focused on IPC indicators is in place based on priorities identified by the institution or facility. It is important to monitor both process indicators and infrastructure indicators. Reporting shall be done quarterly, but in case of outbreaks, as necessary. Feedback shall then be given in real time. Timely and regular feedback of auditing reports on the state of IPC activities or performance is given to all audited persons and relevant staff, hospital management and senior administration, and IPC team and committee. There are available IPC tools to collect data in a systematic way, which include those that assess infection control program and infrastructure, infection control training, competency, and implementation of policies and procedures, and systems to detect, prevent, and respond to healthcare-associated infection. Let us now move to Chapter 7. Bed occupancy rate at any given time shall not exceed the designated authorized bed capacity. The standard bed occupancy rate is 80 to 85%. Authorized bed capacity for each level of facility shall be followed according to the current DOH issuance. Next, there shall be 1:1 ratio of patient to bed. Surge capacity management plan shall include the contingency of dedicated beds, appropriately placed, and protocols of activation. Appropriate staffing levels shall be assessed according to patient workload using national or international standards. For hospitals, minimum of 1 infection control doctor and 1 infection control nurse, ratio of at least 1 full-time infection control nurse for every 100 hospital beds. The design of hospital wards shall be according to the standard designs set by the Department of Health. Overcrowding shall be reduced by optimizing operational processes. The facility shall establish a system for patient flow, such as unidirectional foot traffic, within the health facility. An appropriate triage system at the emergency and outpatient departments shall be implemented. Patient navigation shall be established through the referral system within the healthcare provider network. Last but not the least, we will discuss the brief overview for Chapter 8, Standards on Built Environment, Materials, and Equipment for Infection Prevention and Control. A safe and sufficient quantity of water shall always be available from an improved source on the premises to perform basic IPC measures, including but not limited to hand hygiene, environmental cleaning, laundry, decontamination of medical devices, and healthcare waste management. These shall be in accordance with the Healthcare Waste Management Manual and the latest and updated guidelines on Washington. There shall be a minimum of 2 functional, improved sanitation facilities available on site, 1 for patients and 1 for staff. Functional hand hygiene facilities shall always be available at points of care and toilets. These facilities shall include soap, water and single-use towels, or if not available, alcohol-based hand rub. There shall also be 1:10 sink-to-bed ratio in healthcare facilities, and hand washing stations shall be within 5 meters of toilets. Sufficient and appropriately labeled bins to allow for healthcare waste segregation shall be available. Waste shall be treated and disposed of safely in compliance with the latest or updated national standard on the design, construction, operation, and maintenance of septic tank systems. The facility layout shall allow adequate natural or mechanical ventilation, decontamination of reusable medical devices, triage, and space for temporary cohorting, isolation, physical separation if necessary to prevent transmission of infectious pathogens. Facility layout and construction shall be in conjunction with the latest or updated rules and regulations governing the licensure of healthcare facilities. Adequate ventilation throughout the facility contributes to maintaining a hygienic environment and can be minimally accomplished via the presence of functional windows and doors that allow at least 6 to 8 air changes per hour for natural ventilation. For airborne infection isolation rooms and ER or triage areas, 12 air changes per hour is recommended, while up to 15 air changes per hour may be recommended for operating, procedure, or delivery rooms. Sufficient and appropriate IPC supplies and equipment and reliable power or energy shall be available for performing all IPC measures according to minimum requirements, including all standard and transmission-based precautions, as applicable. Lastly, adequate lighting shall be available during working or operating hours for providing continuous and safe care. That is it for the Manual of National Standards in Infection Prevention and Control for Health Facilities, 3rd edition. From the Health Facility Development Bureau, Miramin Salamat, Po.